I'm Dan Hilleman. I'm a professor of pharmacy practice at Creighton University in Omaha, Nebraska, and I, along with Dr. Mark Malesker, will be teaching the majority of the Advanced Critical Care Therapeutics course, and I'm predominantly going to be covering the cardiac topics. Dr. Malesker obviously is going to be presenting those topics that are more along the lines of the critical care therapeutics. So today, the first presentation that I have for you is going to be on acute coronary syndrome. We'll actually have 2 lectures in acute coronary syndrome. One is going to be on ST elevation myocardial infarction. The second lecture will be on non-ST elevation acute coronary syndrome, which includes non-ST elevated myocardial infarction and unstable angina. And at least in the acute phase, those 2 disease states are managed typically in similar fashion. So we'll be covering those in one lecture. So obviously we're going to be using PowerPoint slides to guide us through these presentations. I will be referring to the PowerPoint slide by number, and that I think will help those of you who choose to access these presentations using audio only will allow you to stay on the same page. Dr. Malesker, I think, has done the orientation, but just to remind you that with each lecture there are some recommended readings. There are required case studies that need to be completed as a homework assignment, and then of course there are a quiz, if you will, an exam, a brief exam that follows each presentation that need to be completed within 1 week of the availability of this lecture. So typically these become available on Wednesdays. The homework and quiz needs to be completed within the 7-day period, and it's best not to wait to the last minute. I really recommend you get these things done at least by Tuesday. If you wait until Wednesday, the cutoff, you could end up not being able to complete the assignments and lose some points that way. So if you go to open your blue line, and if you're just using audio, slide 1 is simply a title slide which says acute coronary syndrome, and so we're going to move on to slide 2, and this basically gives us a definition of acute coronary syndrome. This is a nomenclature that has been in use for probably a dozen years now. We used to just talk about patients having acute MI or unstable angina, but the definition, the nomenclature has gotten a bit more sophisticated. And basically acute coronary syndrome is a constellation of clinical symptoms that are consistent or compatible with acute myocardial ischemia. And when a patient presents with chest pain, which is the most common presenting finding of acute coronary syndrome, you can't tell whether that patient's having a heart attack or not simply on the basis of symptoms. Severity, duration, quality, those are all things that we look at. But the most important thing to do, the first thing that we do in patients that present with chest pain, is to get a 12-lead electrocardiogram. And this is done many times in the ambulance by paramedics that can then transmit the EKG by fax or wirelessly to the emergency department for interpretation. But you don't give aspirin, you don't give nitroglycerin, the first thing that you really need to do is to get that 12-lead EKG, because that tells you if the patient has ST segment elevation myocardial infarction. ST segment elevation myocardial infarction is a true medical emergency that requires triage and management as rapidly as we can afford to offer that therapy to the patient. If there isn't evidence that the ST segments are not appropriately elevated, then you're dealing with non-ST elevation acute coronary syndrome. And there are really two outcomes of patients that develop non-ST elevation acute coronary syndrome, one of which is that they go on and develop myocardial infarction, which then is called a non-ST myocardial infarction, or Stemi. And that's basically a diagnosis that's made on the basis of positive cardiac enzymes. Or the patient could end up with negative enzymes, and if we have sufficient evidence of coronary disease, would be labeled as having unstable angina. Now, obviously, there is another outcome. Patients who present with chest pain may, in fact, not have cardiac disease at all. If you look at the, if you will, epidemiology of chest pain in the emergency department, the most common cause of chest pain in the emergency department is actually gastrointestinal, followed by musculoskeletal causes, and then lastly cardiovascular. So even though we think cardiovascular disease because of the severity of adverse outcomes associated with it, many patients who present with chest pain, in fact, do not have cardiac disease as a cause of their chest pain. So if we go to slide 3, this slide basically just gives us some of the numbers in terms of admissions to hospitals in the United States. The number of patients who present with acute coronary syndrome, about 1.57 million hospital admissions, and of those, the majority end up with non-ST elevation MI or unstable angina, about 1.24 million. A smaller number, 330,000 of those, are STEMI. And so I guess in some sense that's a good thing, only because generally patients who suffer STEMI, ST elevation myocardial infarction, have higher mortality rates, have more complications than the patient that presents with non-ST elevation MI or unstable angina. So the reality is that STEMI is a less frequent presentation in the patient that ends up being admitted with acute coronary syndrome. So if we go to slide 4, then and look at the pathophysiology of acute coronary syndrome, the vast majority, probably 95% plus of patients who present with acute coronary syndrome, the pathophysiology is that these patients have some atherosclerosis in the coronary artery. They have plaque buildup. That plaque over time tends to rupture, ulcerate, erode, and the contents of the plaque spill out into the coronary artery lumen. And that initiates a process of clot formation. That foreign material, which is part lipid, part other, smooth muscle cells, etc., when it's exposed to blood flowing through the coronary artery, will initiate a process where clot forms. And we'll talk about what makes up clot in the arterial side, particularly in the coronary arteries, but platelets and fibrin and thrombin are all involved in this process. So it's partially occluded because you've got plaque rupture and contents of plaque spill out into the lumen, but really what generally occludes the artery is blood clot, it's thrombus. So the pathophysiology of acute coronary syndrome, both for STEMI and non-STEMI, is plaque rupture with superimposed clot, and the best way or easiest way to restore blood flow is to get rid of that clot. And there's a couple of ways that we can do that. Total occlusion, which essentially limits blood flow through the artery. You have zero flow through the artery, if you will, or essentially zero, those are the patients that end up with STEMI. Whereas patients that have subtotal or partial or perhaps even intermittent total occlusion are the patients who present with non-ST segment acute coronary syndrome. Now, we know that there are certain types of plaque, those with thin fibrous coverings, the epithelial cover of the plaque that's thin, those are plaques that tend to rupture. But why some patients develop STEMI, others non-STEMI, we really don't know the reasons for that. It's a source of intense research to try to figure that out, but right now we don't know why one patient with plaque rupture and clot develops STEMI and another non-STEMI. So if we go to slide 5, this is the slide that basically demonstrates what are the components of coronary thrombus. And you can see that initially it's a platelet that comes to that site where you have disruption in the lining of the artery. The platelets adhere, they're activated, they aggregate, they adhere to the site trying to plug the hole in the artery wall. Thrombin comes in and attempts to start forming clot. Fibrin is involved. And so ultimately, when one looks at the management strategies that we use for acute coronary syndrome, we have typically a multi-mechanistic approach, because we use antiplatelet drugs, we use antithrombotic agents like heparin, and for some patients, thrombolytic or fibrinolytic therapy remains a good option. So the progression of development of coronary thrombus involves a number of variables, and so our treatment approach is usually multifactorial. If we can go to slide 6, there are some rare causes of acute coronary syndrome, and we can't rule these out, and I think it's probably worth mentioning that in fact there are patients who present with acute coronary syndrome for reasons other than plaque rupture with clot. One potential cause is coronary vasospasm, and spasm may play a role even in patients with plaque rupture and thrombus. It's under neurohormonal control, but some patients have been described as having acute myocardial infarction with no atherosclerosis and end up with myocardial infarction primarily due to coronary spasm. This has been referred to as Prinz-Nettles variant angina, and in severe form can cause heart attack. There are patients that have marked progression of atherosclerotic plaque to the point where they have 99% blockage of an artery, and a number of variables can occur where plaque rupture does not occur, but patients still develop myocardial infarction or acute coronary syndrome. The mechanism of infarct in patients that have had angioplasty and stenting is a bit different. They develop in-stent restenosis, where there is smooth muscle cell proliferation. What happens when angioplasty is performed, that part of the artery is traumatized, and so the mechanism that occurs is the artery develops a scar on the inside of the artery, and that scar is predominantly smooth muscle cells, etc. And that scar can become large enough that it can block the artery, and so there are patients who develop infarction after deployment of intracoronary stents. Emboli that occur other parts of the body have occasionally end up lodging in the coronary artery. They've been described in the literature again, but not a very common reason for heart attack. It's very unusual to see an emboli from a peripheral artery end up floating into the coronary artery, or from the heart into the coronary artery. So simply, I think you need to be aware that there are some rare cases where it's not the traditional pathophysiology. So if we look at slide number 7, this is kind of a quick overview of the diagnostic process that we need to go through in a patient we suspect has acute coronary syndrome. Obviously, patients have to have some symptoms that bring them to medical care, whether it's chest pain, which is most likely, or shortness of breath, diaphoresis, perhaps nausea, vomiting. Remember, there are some patients that have silent infarction. Most likely, this would be something that would occur in diabetics who may have some neuropathy and don't feel pain, but not always diabetics. The percentage of people that have silent infarcts are relatively small. Most patients do present with symptomatology, but that should lead you, particularly chest pain, to get that 12-lead EKG as quickly as you can. You don't ask for the insurance card, you don't give aspirin. I mean, find out what the EKG tells you, and if it's ST segment elevation, then that's a medical emergency. If you don't have ST segment elevation, then you're dealing with non-ST acute coronary syndrome. That's the presumptive diagnosis initially. Those patients are managed a bit differently. But for all patients with acute coronary syndrome, serial EKGs and then serial cardiac enzymes, or what now are being called cardiac biomarkers, need to be ordered. And on the slide, on slide 7, there's a table that outlines the primary cardiac biomarkers that are used in the diagnosis of acute coronary syndrome. Now, with Stemi, oftentimes the enzymes are not necessarily all that helpful because you've got ST segment elevation on the EKG. But for non-ST-ACS, enzymes are crucial for making a diagnosis. And I think the important thing you recognize is that when you look at the troponin test versus the creatine kinase MB isozyme test, their pharmacokinetics are not all that different in terms of time to initial appearance in the bloodstream, somewhere between 3 and 12 hours. The time to peak is about the same for troponin and the creatine kinase. We use primarily troponin I. I don't know very many institutions that use troponin T, but its time to peak can be a little more variable. But where I think the real difference is in terms of biomarkers is the duration with which creatine kinase remains elevated is much shorter. 48 to 72 hours, essentially it's cleared, it's gone. It will return to normal. Whereas with troponins, those will remain elevated for up to 10 days. So patients that have had a history of chest pain 3 days, 4 days prior to admission, who had an infarct, the use of troponin there may be very helpful in terms of reaching a diagnosis of myocardial infarction. On this particular slide, I think we're on slide 8. Just to review, and I think most of you have probably seen these kinds of evidence recommendations. With the practice of evidence-based medicine, most of the experts that convene to put together expert guidelines use criteria to, if you will, stratify strength of recommendations. And so with most cardiology practice, and in fact the readings that I've recommended for all of my topics for the most part come from the American Heart Association or the American College of Cardiology. But on this slide you'll see that there are 3 classes of recommendations. Class 1 recommendations clearly benefit outweighs risk, and essentially every patient should be afforded that treatment or that procedure. Class 2 recommendations, benefit still exceeds risk, but for a 2A recommendation, that benefit is still substantially greater than risk, and it's reasonable for most patients to consider receiving that therapy or procedure, although additional data would be helpful to give us more confidence that that intervention, would be better served in terms of patient management. Class 2B recommendations, the benefit risk may be equivalent. There may be a slight advantage in terms of benefit, but generally, if it's a Class 2B recommendation, you can consider using the treatment, but you probably have to have a pretty good reason to consider using a drug that's a Class 2B recommendation or a procedure. These are generally, we tend to stay away from recommendations that are Class 2B, unless, again, there's special circumstance. And then Class 3 essentially means that risk of the intervention or procedure outweighs the benefit. And so these are treatments that are generally considered to be contraindicated. They're considered to be harmful. And I don't know that anyone would consider a Class 3 management strategy for any patient. Now, there are levels of evidence, level A, B, and C. If you look at the bottom part of the slide, it tells you what amount of data is available. And obviously, level A means you have multiple randomized, well-controlled studies, clear-cut evidence that the drug works or it doesn't. There are Class 3 recommendations that have level A evidence. The level of evidence has nothing to do with the class. It's just the strength of the data. Level B typically means you have one study. You may have just one meta-analysis. And the data may not be all that strong. Although there is still some evidence. You have trials to look at, but they may not be the best quality. And then finally, level C is primarily anecdotal, historical, expert opinion. For treatments that have been around for a while, for instance, the use of sublingual nitroglycerin to abort acute angina attacks, they're very limited, if any, randomized data telling us that sublingual nitroglycerin should be used for acute angina attacks. But in fact, it's obviously a Class 1 recommendation, but the level of evidence is generally C. So I think I think it's important that you recognize how the expert panel comes up with recommendations. What the class and level of evidence means. I'm not going to be a real stickler in terms of you need to know what every recommendation, where it fits into this classification. But as you read through the materials, you at least need to understand what this represents. So, just to talk a little bit about ST-elevated myocardial infarction in terms of management, there's an adage that's been around for many years, and that is basically time is muscle. The longer that you have lack of adequate blood flow to the myocardium, the more myonecrosis is going to occur. With the brain, when you're anoxic and the brain has been deprived of oxygen for 6 minutes, you have substantial brain death, a substantial amount of brain that's dead. Whereas with the myocardium, there's a longer period of time. The progression of myonecrosis takes a longer period of time, and it moves in what we know from animal studies in a wave front phenomenon. So it moves from basically the endocardial surface to the epicardial surface in a wave-like fashion, and it's possible, if you restore blood flow, to, if you will, abort or terminate the heart attack in progress. So the key is that in Stemi, there's no blood flow getting to a particular part of the heart. Whatever artery is blocked, the heart muscle that artery feeds is not getting oxygen, and it dies slowly, but it takes some time. As you can see from the slide, the only way to adequately manage patients with Stemi is to improve blood flow. And when you have zero blood flow getting to muscle, you can reduce the metabolic demand of that muscle somewhat, but you can never bring it down to zero. You can give beta blockers and nitroglycerin and other drugs that reduce oxygen demand, but it never gets to the point where it reaches zero. So you're always going to have some necrosis unless you can restore blood flow. And there's really only two ways of doing that. One is to use the enzymes, the lytic agents which dissolve blood clot, or the other is mechanical, where an angioplasty catheter, a guide wire is actually punched through the clot, the balloon is inflated, and clot is basically macerated, dissolved, and the artery is opened. More than 30 minutes of hypoxia to the heart leads to myonecrosis. We know that occurs. And that at about 90 minutes, if you can reperfuse patients within that time period, you salvage about half of the myocardium that's at risk in patients. So, the earlier the better. 90 minutes, you can stop the infarct about halfway through. 6 hours, there's very little evidence that you salvage a lot of myocardium at that point. One other issue that's important to note is that when you use thrombolytic therapy, the longer the time that the clot has had to be organized, the longer the time the clot has solidified, the less effective the enzyme is going to be in terms of dissolving that clot. So the more organized the clot, the longer that it's been in existence, the less effective the fibrinolytic drugs are going to be. The guideline cutoff for intervention is 12 hours. So by definition, if you have a patient who presents with chest pain that occurred 12 hours prior to admission, you still, according to the guideline, should administer lytic therapy or use PCI to open that artery. And in fact, beyond 12 hours, if you have evidence of ongoing myocardial ischemia, chest pain, ST segment elevation, you can give lytic or PCI. Generally, you prefer PCI at that point. But you can treat beyond 12 hours, up to 24, in fact, if there's evidence of ongoing ischemia. Now, in clinical practice, sometimes patients are not certain. When did your chest pain start? Well, it was the middle of the night. I don't know exactly what the time of onset of pain was. Or the pain came and it went, and it came and it went. And so what do you use as the time to start the clock, so to speak? So I think, this is the art part of practicing medicine. And we know what the science says, which is 12 hours, but figuring out when the chest pain started sometimes is not, cut and dry. So if we go to slide 10, this particular picture has been taken basically from the American Heart Association guidelines. And it gives us what I guess we would consider to be the optimal time course of events in a patient who presents with ST elevated myocardial infarction. Again, medical emergency. Patients develop chest pain. They should contact 911, call their emergency medical service. The dispatcher gets a hold of the paramedic squad within a minute. They're on the scene. They do what they need to do on the scene, transport the patient, and then the patient is treated at the hospital. And all of that you'd like to see take place within about 2 hours, 120 minutes. That's the optimal time from onset of symptom to intervention. The first hour is often called the golden hour, and this occurs, or it's a term that's used in a lot of scenarios for trauma, any emergency situation. The first hour is always the most important in terms of improving survival. So if you can get patients treated in 60 minutes, their survival is substantially greater than patients that are delayed by 3 or 4 hours. Now, having looked at this graph, you'll notice that patients are supposed to call within 5 minutes after the onset of chest pain. Well, that doesn't happen all that often. I mean, we're instructed to tell patients discharged with acute coronary syndrome that if they have chest pain, call right away. But we have patients that delay for hours sometimes. They're in denial. They don't want to have heart attacks, obviously. So, there are parts of this schematic, patient delay, transport delay because of weather or other issues. But one thing that we as healthcare providers can do on our end is once the patient gets to the hospital, that's when we can take over and manage these patients within the appropriate time frame, and we'll talk about that in some detail. Slide 11 looks complicated, but it's really not. We'll walk through this. But this is the recommended algorithm for managing patients who present with ST-elevated myocardial infarction. So obviously, if you start at the top, the patient who has ST segment elevation first needs to be a candidate for reperfusion. Have they presented within 12 hours? Are they willing, if they're admitted to an institution that can do PCI, are they willing to have PCI? I mean, most patients, obviously, with heart attacks are willing to, know that this is life-saving therapy. So the easy part of this, I think, is the patient that's admitted to a hospital that can do PCI. The patient's transported immediately to the cath lab. They have an angiogram. They find the artery that's totally occluded. You can prep them with heparin, aspirin, anticoagulant therapy before you do the PCI, and we'll talk about some of that, what's appropriate, inappropriate. They have the diagnostic angiogram, and then majority of what we've learned from these acute coronary syndrome studies is that about 99% will end up having PCI. Angioplasty, and most will get an intracoronary stent. About 1% will have coronary disease where they've tried PCI and it's failed, and then they need emergent cabbage, and that happens about 1%. It's unusual, and I can't tell you what percent. There are very few patients who don't have either procedure that end up just being treated medically. That they look at the coronaries and there's nothing, there's no significant atherosclerotic blockage. Now, it happens, but it's certainly less than 1%. The complex part of the algorithm are those patients who live particularly in rural areas. They're taken by ambulance to a medical facility that does not have a cath lab. And so then the question is, and it's a decision that has to be made very rapidly, do we transport to a hospital that can do PCI, or do we administer lytic on site? And there are a number of variables that will affect that decision. If the patient is going to be transferred for primary PCI, then you do prep them with the appropriate drugs on the way. They can get aspirin, beta blocker, they can get some heparin on the way to the other hospital, for angiography and then a definitive therapy. If the decision is made to keep the patient at the admitting hospital and use lytic therapy, that should be given, right away, as quickly as possible. And obviously there's a checklist for relative contraindications for lytic therapy, and we'll talk about those briefly. But even when lytic therapy is administered, the decision still has to be made. Is this a patient that's at high risk or at not high risk, if you will? Because the high-risk patient probably should still be transferred as quickly as possible once you get lytic therapy in that patient. And part of the reason is, and we'll talk about this a little bit later, lytic therapy only reperfuses. It only opens up arteries at a rate of 65 to 70%. What the flip side of that is that you've got therapy, and this is across the board when you treat large populations. We know that at least a third of patients that we treat with lytics fail. the enzyme doesn't adequately open the artery, and they need mechanical intervention. They need PCI to open that artery. If the patient's relatively low risk, there is the provision of keeping the patient at the facility where they receive lytic therapy. I think that's an unusual practice today. Unless the patient's just totally against the transfer, they're totally opposed to having coronary angiography. I think in today's modern world of best practice, that even the lower risk patients are probably going to be transported to a hospital that can do PCI. And if they reperfuse, they don't have to be transported, they can be transported at a more leisure pace, if you will. They don't have to be sent by helicopter, etc. But that's basically what the treatment algorithm, so it's not as complicated as it looks, but the toughest decisions are those patients who get admitted to a rural hospital, no cath lab. Do we treat with lytic here that can be given very rapidly, or do we put them on the helicopter or an ambulance and send them away for PCI? And I think that the concern is that we know that PCI, when we compare it to lytic therapy, is generally more effective. On average, PCI works 98% of the time in terms of opening the artery. So the pendulum in terms of the option of using thrombolytic therapy or PCI has swung towards PCI. And the danger is that I think there are institutions that have forgotten that lytics are class 1A recommended therapies. They are life-saving. And so if there's going to be a delay in transporting that patient, don't sit and watch the patient infarct. Give them lytic. If it's going to be an hour before you can get them into an ambulance or on a helicopter, and it's going to be another hour en route, it probably would be better to use lytics in those patients. And we'll talk specifically about what the guidelines tell us about how that decision should be made. Slide 12 basically just gives you a cartoon depiction of what the two basic strategies are for treating STEMI. One is to use the enzyme, which dissolves clot, which doesn't do anything for the atherosclerotic plaque. Remember that when that enzyme wears off, that plaque is still sitting there, and clot can reform. So, the definitive therapy needs to be done after you give lytic therapy. The advantage of PCI is that you can open that artery up, you can dilate it properly with the balloon, you can put a stent in, and generally that's the management for that artery, and you don't need to go back in and do anything else with that artery down the road, at least during that hospital stay. So stenting specifically does not do anything necessarily for the acute phase of myocardial infarction, but it does improve outcome down the road. It prevents basically stent restenosis, particularly if you use your drug-eluting stents in that setting. So slide 13, reperfusion strategies. For the sake of sounding redundant, obviously it's important to recognize that you have two options: lytics or what is called mechanical or angioplasty. Mechanical intervention, as I've alluded to, is always more effective than lytic in most settings. I don't know of any evidence that lytics have ever been shown to be better than PCI. A couple of studies have shown that early in the course of management they can be equivalent, but I would almost always think that PCI would be a better approach if it can be administered in a timely fashion. The factors that kind of affect our decision about choosing one type of therapy or another, there are some general variables. One is, if it's very early after the onset of symptoms, the first 3 hours or so, lytics work pretty well in that setting. So if somebody shows up early, that's been an hour or 2 hours since the onset of symptoms, you're concerned about transfer, there may be some delay in getting that patient transferred. Early in the course of Stemi, lytics dissolve clot pretty well. So the first 3 hours in particular, and if there's going to be a delay to PCI, then lytics work well. The other is that if you have a patient that's at very high risk, they have an anterior MI, they may have mechanical damage, they've got a ruptured mitral valve as a result of the infarct, whatever that puts this patient at high risk of mortality, generally PCI is preferred. Patients that have bleeding complications, patients that have contraindications to lytics, obviously PCI is preferred. And then the time to transport issue, trying to make this as simple as possible. We have a couple of concepts that we talk about: door to balloon, and then door to needle. Door to balloon, and when you say door, the original thought process, this was the door to the hospital. So door to balloon, if you're talking about the emergency department to the time that they can start PCI, the balloon being the angioplasty balloon, that should be 90 minutes in hospital. But you'd really like the door to be door to the ambulance, and the time that the patient gets in the ambulance to the cath lab and gets the balloon in place. If that can be kept at 90 minutes, then that's really what we want to accomplish. Door to needle, on the other hand, is from presentation to the hospital or possibly to the ambulance and to the time that lytic is actually administered. And that's typically, that door to needle time should be 30 minutes or less. So if you think about door to balloon and door to needle, door to balloon is 90 minutes, door to needle is 30 minutes. So even under optimal circumstances, the delay to do angioplasty during the setting of Stemi is always going to take an hour longer, because you have to get the patient to the cath lab, you have to get a femoral or radial stick to get your catheter in, you have to shoot the coronaries, you have to interpret the coronary angiogram, and then get the balloon in place and do the dilation. So by definition, the angioplasty is always going to take longer to accomplish than if you're going to give lytic therapy. Slide 14 is a table that tells you when lytic would be preferred and when PCI would be preferred, and these are not necessarily mutually exclusive. But again, if it is less than 3 hours from the onset of symptoms and there's going to be a delay to getting the patient to a facility where they can have PCI, then lytics would be preferred. If the invasive strategy is not an option, the patient says, no way, I am not going to allow you to do an angiogram. I don't want to accept that. I mean, for whatever reason. It may not make sense, but if they refuse cath lab, PCI, then the only option you have is lytic. And then again, the issue of delayed to transport or delayed to PCI. If the transport is going to be prolonged, we talked about this just a minute ago, but if the door to balloon compared to door to needle time is going to be longer than an hour, that delay, when the normal delay is about an hour, but if the delay is going to be longer than an hour, particularly if it's going to be an hour and a half, 2 hours, then lytics would be preferred, especially if it's early, first 6 hours. And then, of course, if your door to balloon is going to be longer than 90 minutes, then lytic would be preferred. In other words, if there's going to be a delay for some reason in doing angioplasty, then it's probably better to give the lytic, assuming the patient's had, you've had the checklist and they don't have contraindications to lytic therapy. PCI is preferred if obviously you can get the procedure done within 90 minutes from presentation to preferably the ambulance or helicopter, but also even if it's presentation to the hospital. If the door to balloon compared to door to needle is less than an hour, then that's great. Your PCI would be preferred. If the risk of mortality due to STEMI is high, patient's cardiogenic shock, anterior infarct, high-grade conduction disturbance, those patients would do better with PCI. Patients who have contraindications to lytic. Predominantly, these are things that would increase their risk of bleeding, particularly intracranial hemorrhage. Late presentation, beyond 4 hours, lytics are not very effective or less effective. Again, the window is 12 hours, but we know from the data that 4 hours out, the lytics are not going to be as effective. And then if your diagnosis of STEMI is in doubt, in other words, you've got a 12 lead, and there's ST segment elevation, but it's a millimeter in one lead, and there's bundle branch block or whatever. You're not certain if it's new onset bundle branch. This is a physician decision looking at the EKG, and they say, there's probably STEMI, but I'm not absolutely 100% sure. It's probably better to do PCI because you can do angiography, and if the coronaries are clean, you haven't lost anything. But if you give lytic and they don't have coronary disease, they may end up having intracranial hemorrhage, and you've given them a dangerous, potentially dangerous drug for no reason. So, slide 15, I believe this is slide 15, excuse me. My vision is not as good as it used to be. But this table shows you the available fibrinolytic drugs that are still, I think most of them are available on the market. The streptokinase derived from a streptococcal origin, relatively cheap, but I don't know that it gets used much in the United States for MI. It's not as effective as the fibrin-specific drugs. We know that from Gusto, the original trial, that compared to alteplase or TPA, that streptokinase did not work as well. Mortality rates were not reduced to the same extent. It also, has some antigenic property which can cause allergic type reactions. That I don't know that those are necessarily dose limiting for most patients, but it is a nuisance. I think the only reason that it gets used, particularly in other parts of the world, is that it's relatively inexpensive. The fibrin-specific drugs, alteplase, which is TPA, retaplase, which we refer to as RPA, and tenecteplase, or TNK, or TNCase, are fibrin-specific drugs, and they're all probably equally effective. What we have in terms of data is that we know that alteplase has been compared to RPA in a mortality trial and shown to be equivalent. Alteplase has also been compared to TNK in a mortality trial and showed to be equivalent. But we do not have direct head-to-head comparative data of RPA and TNK. So I guess if you're a logician, someone who believes in logic, you could argue that, well, if A equals B and B equals C, does that mean that A equals C? Well, we don't know, but I think most people have concluded that RPA and TNK probably equal in terms of their ability to cause reperfusion and reduce mortality in STEMI. Most institutions have chosen one or the other of the bolus drugs, RPA or TNK. RPA is a double bolus, 10 units or 10 milligrams given 30 minutes apart. TNK is a single bolus. The only, I guess, limitation of TNK is that its dose is weight-based. And in some early studies, there were some concern that patients may have been underdosed simply because where do you get weights on patients who are having heart attacks? You either look in the old record, if there is one, or you ask the patient, and the patient may underestimate how much they weigh. And that's the typical. If they're off, it's typically they're going to tell you they weigh less than they do. I don't think that either drug, the double bolus with RPA or the weight-based part with TNK is a major limitation with either drug. The reason that we've chosen these drugs is that the door-to-needle time is more rapid than it is with alteplase, I believe, because alteplase requires a little more in terms of mixing the drug, in terms of it's got to be run by an infusion, it's a bolus, and then there's a rapid infusion, and then a slower infusion. With the bolus drugs, it's 2 shots, 1 shot, you're done. And I simply think that they're just easier to use in a STEMI setting. Now, in terms of formulary, alteplase is the only drug approved for ischemic stroke. So most places have to keep, most larger institutions have to keep some alteplase on the shelf for ischemic stroke, and then RPA or TNK for infarct. And alteplase also gets used for some of the peripheral indications, arterial clot, in the lower extremities, sometimes DVT. You can use RPA as an infusion, but it's really not technically FDA approved for that indication. So I think the reality is that most institutions that use lytic therapy for STEMI is going to be one of the bolus drugs, and I don't think there's a whole lot of difference between the two in terms of efficacy or safety. If we look at slide 16, and I'm not going to read these are the relative and absolute contraindications to the use of lytic therapy for STEMI. So there is a long list here that needs to be looked at, and most emergency rooms, most emergency medical transport systems, the ambulance, helicopter, will have a checklist for STEMI. What are the things that we know we need to do to manage these patients more efficiently? What therapy do they need? Obviously, they need aspirin. Most need beta blocker. Most need an antithrombotic regimen. And then, if they are going to get lytic, you have these, basically on a checklist. Because you should be able to get through this checklist very rapidly, 5 minutes, 10 minutes, and still get lytic started within that 30-minute door-to-needle time. So it's better served to have this written down rather than trying to memorize this and commit it to memory. That's my personal thought. But there should be an acute MI, acute coronary syndrome, or STEMI protocol that has this kind of information printed out, and it allows you to go down the checklist, and it will make your life easier. Slide 17, there is some data supporting giving lytic therapy in the field, what's called pre-hospital lysis. The data is mixed predominantly because a couple of the studies, the difference in time between giving lytic in the ambulance or in the field versus giving lytic in the hospital the difference was small. 5, 10, 15 minutes, sometimes 30 minutes. And so you would not expect to see large differences in survival with short time interval differences. If it's going to be a long delay to get to the hospital to give lytic, you're in a very rural area, then giving lytic in the field can be life-saving. The guidelines suggest that it's reasonable to set up protocols for pre-hospital lysis under 2 circumstances. One is if a physician rides in the ambulance or on the helicopter, and there are a couple of countries where physicians ride in ambulances. In Israel, in France, there may be others, but obviously the physicians there can see the EKG, do the checklist, give lytic right away if that's the approach that they want to take. The other is basically if the emergency medical system personnel can be adequately trained to recognize and treat STEMI. And that may require faxing or sending wirelessly a copy of the 12-lead EKG to a physician in the emergency department who then calls back and said, this is STEMI, give lytic. The places that have the manpower, the resources to do this, typically are large urban areas where transport to hospitals for PCI is going to be short anyway. So the bottom line is I personally don't think pre-hospital lysis has caught on to any great extent. Again, there may be some very rural areas with limited resources where pre-hospital lytic therapy makes some sense. But for a lot of places, it's of limited value. We talked about a couple of things that are on the slide. Get the EKG transmitted to a physician as early as possible. If you can send it wirelessly, you can send it by fax, whatever mechanism from the field. And also have a Stemi protocol. Have a checklist of things that need to be completed, particularly prior to getting to the emergency department, so that those things are already accomplished, before you end up treating the patient. I think this will speed up the time to intervention. Slide 18. There have been some studies looking at giving lytic therapy with the IV antiplatelet drugs, what we call the glycoprotein 2B3A receptor antagonists. These are drugs like abciximab, which is Riapro, eptifibatide, which is Integralin, tirofiban, which is Aggrastat. So they did these mortality trials looking at giving half-dose lytic with full-dose IV antiplatelet drug. No impact on mortality compared to lytic therapy alone. This was not PCI. This was basically, lytic plus IV antiplatelet versus lytic alone. So no big advantage. There were some minor differences in secondary outcomes, less reinfarction, less ischemia, but the price was higher bleeding rates. And so, severe bleeding. And so the guideline actually suggests it's a 2B recommendation, which means you probably wouldn't consider using it for most patients. You'd have to have an awfully good reason. And it is a level of evidence of A, which means the studies were well done. It's just that the treatment was not that effective. So they say it's a 2B recommendation for people less than 75 years, no bleeding risk, who have high-risk infarct, STEMI, maybe cardiogenic shock, who can't get to PCI. In that setting, maybe it would have some role. But again, this is something that has not caught on. I don't know of any institution that routinely uses this as an intervention for STEMI. So primary PCI is the optimal approach for most patients if they can get to an institution in a reasonable period of time. The caveat is you need to have an experienced operator. You need an interventional cardiologist that does an average of 200 PCIs a year, and 36 of those should be for direct treatment of STEMI. You do need surgical backup. Sometimes there are problems during angiography, which means you go for emergent CABG. And as I said earlier, about 1% of ACS patients that are treated with angioplasty end up requiring emergency surgery. There are 22 randomized trials comparing lytics with PCI. And the data is pretty convincing. The mortality rates at 30 days are significantly better with PCI. Reduction in myocardial infarction rates, lower rates of intracranial hemorrhage. The only downside with PCI is that there is a higher rate of major bleeding, but that's mostly related to procedural bleeding, where the sheath is put in the femoral artery or the radial artery, and patients develop subcutaneous bleeding called hematoma. And so that occurs at a slightly higher rate with PCI, but it certainly doesn't limit its ability to save lives. On average, when the door-to-balloon time is less than 90 minutes, then blood flow typically is restored in the infarct-related artery in about 90% of cases. It's probably, in fact, a little higher than that. Emergent CABG I have on the slide about 2%. I think it's closer to probably 1%. And again, stenting can be done at the time that you do the initial PCI, but it's only for long-term benefit. It doesn't really impact short-term survival. It's there to reduce rates of restenosis that occur 3 months, 6 months, 9 months down the road. On slide 20, in the old guidelines, there were a couple of approaches to managing, patients who had STEMI with what is referred to as facilitated PCI or rescue PCI. And the guidelines suggest we no longer use these terms. We shouldn't talk about facilitated or rescue PCI. Facilitated PCI was where you plan to give lytic therapy or you plan to give IV antiplatelet drugs like ReoPro, and then went directly to PCI. And the thought was, well, if you dissolve the clot, then you can do angioplasty and stent, and your outcome will be better. Well, in fact, the opposite occurred. Patients that got lytic or got ReoPro or Integralin prior to PCI in a planned fashion had higher complication rates. They had more bleeding. They actually had higher mortality rates. So facilitated PCI is no longer recommended at all. Rescue PCI, we still do it. It's just that we're not supposed to talk about it. The point is, at the time that the decision is made to go to PCI or to lytic, when you give lytic, because there's going to be a delay to PCI, most of those patients should still be transferred to a hospital that can do PCI, because we know that a third of them are not going to respond to lytic. It's going to fail. The law of averages tell us that it's going to fail in about 30% of cases. So you should be prepared to do PCI for that third of patients, particularly those that are at higher risk. The question is, how do you know that they failed? Short of doing an angiogram and looking in the artery, there are some clinical markers that tell us that patients who get lytic therapy have reperfused. And the two most important are resolution of ST segment elevation and then relief of chest pain. A couple of other things happen. One is when people reperfuse, they have what's called an early washout or early peak of cardiac enzymes. A myocardium that's ischemic that's suddenly reperfused with blood, the contents of those cells oftentimes are flushed out of the cell. But that early peak in cardiac biomarker doesn't help you make a decision early. It's a retrospective phenomenon. You can only tell that it was an early peak after you've looked at the patient's enzymes after 24 hours or so. The other is that some patients who reperfuse will develop what's called a reperfusion arrhythmia, usually a slow idioventricular rhythm. And if it happens, it's great. It tells us typically reperfusion has occurred, but it doesn't happen very often. The majority, 95+% of patients who reperfuse do not have a reperfusion arrhythmia. So it's not a reliable marker of reperfusion. So what the guideline tells us is that total resolution of ST segment, total resolution of chest pain to 0 rarely occurs. So what the recommendation is that you take the ST segment, the lead where you have the greatest ST segment elevation, and if that ST segment elevation is resolved by at least 50% at 90 minutes after you've given the lytic, then that's evidence of reperfusion. If you don't have 50% reduction in that ST segment elevation, then the patient needs to go for PCI, which we're not supposed to call rescue, but in reality it is rescue PCI. We're going to go in, open that artery up because we don't think the enzymes worked. Now PCI on slide 21, there are some complications. Bleeding can occur. The dye that's administered can cause contrast-induced nephropathy. The dye can cause allergy. You have to give a certain amount of antithrombotic, heparin, bivalrudin, whatever. And so there are some, obviously, bleeding complications related to that. Technical problems, coronary dissection, etc., stent thrombosis, stent restenosis. But none of those outweigh the benefits of PCI. I think the importance of this slide is to tell you that yes, when you're dealing with a patient with STEMI, there are some things that can go wrong, but generally we can manage these, and even though they're complications, if we do our jobs properly, the rates of those complications are not all that frequent, and typically they're very manageable. Slide 22, when you do PCI, most patients do need an antithrombotic agent administered. You don't want the sheath that's put in to allow you to thread catheters in. You don't want the sheath clotting off. You also don't want clot forming at the site where you're doing the angioplasty. So there are a variety of options for antithrombotic regimens, and those include unfractionated heparin, the old heparin that's derived from either a pork or a beef source. Has been around forever. It's the short-acting heparin that you give typically by continuous infusion. In the cath lab, typically it's given as a bolus. And typically you give just enough heparin to get the ACT to a therapeutic range, and every lab has their own therapeutic range. You normally monitor heparin with a partial thromboplastin time, but because you're giving pretty big intra-arterial doses of heparin, the activated clotting time is the test that's used to measure the extent of anticoagulation that occurs with unfractionated heparin. You can use low molecular weight heparin, enoxaparin, and there are some protocols for using low molecular weight heparin. The problem with low molecular weight heparin is that the duration of action is longer. Its duration of action is 8 to 12 hours. And so you have to kind of know, did they get enoxaparin in the emergency room? When was the last dose given? And if it was within the last 8 hours, well, then you don't need to give any more. But if it's been more than 8 hours, then you need to give additional low molecular weight heparin, more enoxaparin. You give it IV in the cath lab. And so, there are places, quality institutions that use low molecular weight heparin, but a lot of places don't. I can tell you at the institution I practice at Creighton, we use unfractionated heparin. It makes, I think, our lives easier because of the very short onset, the very short offset. You shut off an infusion of heparin and it wears off, literally, within minutes. Its effect is gone. Fondaparinux, if someone gets fondaparinux prior to going for PCI and it's STEMI, the recommendation is actually to switch the patient to a factor 2A inhibitor. Well, what are factor 2A inhibitors? Well, unfractionated heparin predominantly. Remember, the low molecular weight heparin affects factor 2, but it also affects factor 10. And so it's really more of a balanced, affect factor 10 more than factor 2. So unfractionated heparin is more of a balanced anticoagulant. It affects factor 2 and factor 10. Low molecular weight heparins are predominantly factor 10 inhibitors. They do have some factor 2 activity. But as you see on the slide here, slide 22, if the patient got fondaparinux, which is unusual, the recommendation is to switch to unfractionated heparin. Bivalirudin, which is a direct thrombin inhibitor, is indicated to be used in angiography, in PCI. And there is a trial that we'll talk about a little bit later where bivalirudin was compared with heparin and glycoprotein 2B3 receptor antagonist. And the main advantage of bivalirudin, it appears, is that it's associated with less bleeding than if you give heparin plus, let's say, Riopro or heparin plus integralin. So that is where the guidelines suggest that bivalirudin may play an important role, is that if you have a patient that's at high risk for bleeding, they've had a history of a GI bleed in the last week or two, and you take them to PCI, bivalirudin may be a better choice. But patients need to be on one antithrombotic agent at least, during the course of PCI. Now, after PCI is over with, most of the time you can stop these antithrombotic drugs. They don't need to stay on them very long after the PCI, as long as you have a pretty good result. Giving antithrombotic therapy to people that are treated with fibrinolytic therapy is important. Remember, the lytic dissolves the clot, but you've still got a plaque that's ruptured. And once the lytic wears off, the duration of action of lytics are relatively short, 12 hours, 24 hours. Once that effect wears off, and the longer after you administer the bolus, the less effect that you have, clot can reform at the site where you have the ruptured plaque. So the guidelines specifically tell us that we should co-administer unfractionated heparin in particular with the fibrin-specific lytic drugs. And the recommended dose is 60 units per kilo as a bolus, a loading dose, and then 12 units per kilo per hour, which is not a big dose. But the caveat is the maximum dose, regardless of how much the patient weighs, should be no more than 4,000 units as the load and 1,000 units per hour as the maintenance therapy. And generally, you only continue the heparin for 12 to 24 hours after the PCI. Now, if streptokinase were given, let's say you end up practicing in a part of the world where streptokinase is given as the primary lytic agent, you don't have to give heparin because streptokinase produces a more systemic anticoagulant effect than the other three fibrin-specific drugs. The only time heparin would be indicated with streptokinase is if you have another indication. The patient's high risk because they've had a prior embolism, or they've got a large anterior infarct, or they've got AFib, or some other high-risk variable like cardiogenic shock. The only other issue related to antithrombotic therapy has to do with DVT prophylaxis. And it's actually a 2B recommendation because most patients with infarct are gotten up quickly. I mean, they're using bedside commodes the first day. They're walking typically, after they've had PCI. They're up walking as soon as, the sheath is pulled and they've got hemostasis. So unless the patient qualifies for DVT prophylaxis under what's called the medical indication, it's not a big priority for most patients who've suffered Stemi. Now, antiplatelet therapy in the course of Stemi, everybody should get aspirin. Aspirin by itself has been shown to reduce mortality in patients with MI, with Stemi, whether they get PCI or not. The initial dose for patients who have not previously taken aspirin, the minimum is 160, but we really prefer 325. If you give them the baby aspirin, they can chew 4 80 milligram tablets and get a very rapid antiplatelet effect from that. And it's best to give it prior to PCI. Don't wait. Prior to lytic. This is something that can be done while you're mixing the lytic or while they're on the way to the cath lab. Maintenance dose, if they haven't had PCI, then you can put them on 75 or 80 or up to 160. You can give them 325, but if they haven't had a stent in particular or PCI, then you can give the lower dose according to the guideline. Patients that are going to go for PCI, though, generally need dual antiplatelet therapy. They should be on aspirin plus ethanopyridine. And the controversy really is, should you pre-treat with Plavix as early as possible because it has a slow onset of effect and give a high loading dose? Or should we use prasugrel, which we know has a very short onset of effect and a very potent antiplatelet effect? And I think the data right now suggests that for Stemi, prasugrel would probably be a better choice. And part of the reason is that when you have a patient with Stemi, you do your angiography, the majority are going to have a one lesion that needs to be dilated with a balloon. But there may be patients that have severe three-vessel disease, or you can't get the balloon to the site or whatever, And if you pre-treat them with either prasugrel or clopidogrel before you know the angiography, the results of the angiography, and they need cabbage, then both drugs have to be held for 5 to 7 days. 5 to 7 for Plavix or clopidogrel, 7 days for prasugrel. Now, admittedly, it's a minority of people with STEMI where that happens. So I think the approach right now is still most people will give the loading dose of Plavix. As soon as they know it's STEMI, they'll give 300 or 600 as a load, and then 75 milligrams a day as a maintenance. Prasugrel at 60 milligrams as a load, and then 10 milligrams per day maintenance. One caveat with prasugrel is that if the patient has a prior history of stroke or TIA, it's contraindicated. But the data, the Creighton-Timmy 38, which we'll talk a little bit about, which compared clopidogrel and prasugrel, found that in STEMI, prasugrel was clearly better because its effect is peaked at 1 hour after administration. You give a load, it's a prodrug like clopidogrel, but you get a maximum effect at 1 hour, and it has about an 80% inhibitory effect on platelet aggregation. For non-primary PCI, which is really, I guess, those patients that have gotten lytic and it failed, or for some reason there was a delay in treating the patient, they presented late, and they didn't get lytic, and you're just doing PCI down the road, so to speak. If they get lytic, then clopidogrel is the only antiplatelet drug they should receive. Prasugrel has not been studied with lytics, and so right now you cannot recommend prasugrel following lytic therapy. If they did not get lytic and you're doing PCI, again, late, you can use prasugrel, you can use clopidogrel, it's an option. Duration of therapy long-term is if you have a stent, and it doesn't matter, bare metal, drug-eluting, the recommended duration is 12 months. Okay, that's the optimal. The guideline does say, and this is the 2009 guideline, the guideline does say that if there's a significant risk of bleeding, for bare metal stents, you can stop dual antiplatelet therapy at 4 weeks, 30 days. So you can just keep them on aspirin, stop the thienopyridine. But if there isn't an increased risk of bleeding, optimally 12 months is the best for both bare metal and drug-eluting. And there's a little bit of evidence from Creighton-Timmy 38 where they kept the dual antiplatelet therapy going for 15 months. And there's some others that are saying, well, 2 years. But right now the guideline says 12 months. There isn't much evidence of benefit of dual antiplatelet therapy beyond 12 months, but that may change. And again, I want to emphasize the point that if you're on a thienopyridine, either prasugrel or clopidogrel, and cabbage is planned for clopidogrel, you have to wait 5 to 7 days. For prasugrel, 7 days. If not, the risk of bleeding is substantially higher. So that is a consideration in patients that need to go to coronary artery bypass graft surgery. On slide 24, what about giving glycoprotein 2B3 receptor antagonists? Drugs like ReoPro or Integralin, particularly in patients that are going to have PCI. Well, their role has been downgraded. Basically, what the recommendation is that if you have a patient at angiography that has extensive clot burden in the infarct-related artery, you can give the IV glycoprotein 2B3 receptor antagonist at that time. It has a very rapid onset, about an 80% antiplatelet effect, and you give that on top of aspirin plus a thienopyridine. So they're actually getting 3 different antiplatelet drugs. But that's the only indication for using the IV antiplatelet drugs in STEMI at this point. There isn't much evidence that giving them routinely is of benefit in terms of survival. So the recommendation really is selected patients with substantial clot burden. Using them routinely is actually now a 2B, a level of evidence B recommendation. And, so the best evidence is actually with apixaban, but it's not inexpensive. It's the most expensive of the IV antiplatelet drugs. Now, I mentioned earlier bivalirudin, and there is a trial that was published in Stemi where patients were randomized, allocated in open label fashion to heparin plus a glycoprotein 2B3 receptor antagonist, or to bivalirudin with what they call provisional glycoprotein therapy. In other words, if they saw clot burden, they'd give the IV antiplatelet drug. And what they found was that the outcome favored bivalirudin, but most of the outcome was driven by a lower rate of bleeding. So that's why the recommendation is that if you have somebody who's going to PCI for STEMI, you know they've had recent surgery or GI bleed or propensity to bleed, the bivalirudin route may be a good way to go. It's especially important, though, with bivalirudin that you make sure that you've got Plavix or prasugrel and aspirin on board, because bivalirudin as a direct thrombin inhibitor does not have antiplatelet effects, and that's what you're missing by using bivalirudin. With glycoprotein 2B3 receptor antagonists, they have a potent antiplatelet effect, and so there is a slight increase in the risk of stent thrombosis, of blood clot happening at the time of PCI when you use bivalirudin by itself. So slide 25, there are some ancillary drugs that need to be considered in patients that present with STEMI. Oxygen is recommended for all patients, at least for the first 6 hours. It's a 2A recommendation. Certainly if patients have O2 sats less than 90% on room air, then they need to be given oxygen. You know, the question or argument often is, well, if the patient's normoxic, what do you accomplish by putting them on 2 liters of O2 by nasal prong? Well, probably not a whole lot, but it's been done for years and probably isn't going to change. Nitroglycerin in STEMI is only used to relieve chest pain. Waiting to transfer the patient for PCI to start a nitro drip shouldn't happen. Nitrates do not reduce mortality in acute myocardial infarction. They're really indicated for relief of chest pain, myocardial ischemia, to treat hypertension, or to treat heart failure, particularly people with pulmonary congestion, pulmonary edema. So that's where nitrates are most beneficial in the setting of STEMI. There are 3 patients or 3 types of patients where they need to be avoided. They're contraindicated. Patients who are hypotensive, systolics less than 90 or maybe even less than 100. Patients that have taken erectile dysfunction drugs. Even if they've had a dose 48 hours prior to admission, probably avoid the nitrate. And those with right ventricular infarction. So those are the 3 patient settings where giving nitroglycerin would be relatively contraindicated. If you use IV nitro to relieve chest pain, don't give it for longer than probably 24, 48 hours. Wean it off, assess, has the patient redeveloped chest pain? Have they gone to PCI, that kind of thing. So typically, heparin's given up to the point they go to the cath lab. You stop it. They may get some intracoronary nitro, but typically you don't continue it after the PCI. This is slide 26, and obviously analgesia. Morphine is the drug of choice if patients continue to have chest pain despite getting heparin, despite getting beta blocker. And so, morphine is the drug of choice. Meperidine is no longer available at most institutions. But be aware that morphine can cause some bradycardia. It may cause some slight hypotension. It can cause respiratory depression. It can also increase nausea and vomiting. Now, atropine may counteract some of those vagomimetic effects, but you want to be cautious, obviously, with atropine in somebody with an infarct. You can overshoot and cause tachycardia. You can increase ischemia. So, morphine's probably, the drug that gets used. And then stool softeners. You don't want patients straining at the stool or straining, when they're using the bedside commode. So stool softeners are routinely administered, at least during the short-term hospital phase of Stemi. Slide 27, beta blockers. Certainly a reduced mortality in these patients, but probably more of a long-term effect. The recommendation is to avoid the IV beta blockers. There are protocols with metoprolol, atenolol, where you give IV beta blocker early. The recommendation now is to avoid IV beta blocker unless the patient's hypertensive. And the reason for that is that early IV use of beta blockers is associated with a small but important risk of cardiogenic shock. So start the beta blocker in the first 24 hours, but generally start oral. If you really are concerned that the patient has a contraindication to a beta blocker, you might consider esmolol. Short acting, you can shut it off. Don't give it for, it shouldn't be used for more than 12 or 24 hours. But if you have a concern that the patient's going to have a side effect with an oral beta blocker that will persist, then you might give them a trial of esmolol to see how they tolerate it. Drugs that affect renin, angiotensin, aldosterone, the RAS modulators, ACE inhibitors are probably the drugs of choice here, but you don't need to start them early, especially not IV. Consensus 2 was a trial where enalaprilat was given early, increased mortality, and we think it because it dropped pressure, it reduced coronary perfusion. So, patients with infarct should get ACE inhibitors, but they don't have to be started right away. In fact, I think you can probably delay starting them until after PCI. There's no need to give them before they go to the cath lab. And the patients that derive the greatest benefit are those with low ejection fractions, those with pulmonary congestion, those with anterior infarct. They're the ones that are going to derive the greatest mortality benefit. If at some point the patient doesn't tolerate the ACE because of cough, angioedema, you can consider using an angiotensin receptor blocker, but the ARBs certainly are not better than ACE inhibitors. Aldosterone receptor antagonists generally are not given in the acute setting, but for patients who have a low ejection fraction, heart failure, despite being on an ACE inhibitor, they are indicated. The rules are basically that you can't have significant renal dysfunction, so your creatinine has to be less than 2.5 or 2 in men and women. The patient cannot have hyperkalemia, and typically either have to have a low ejection fraction, have heart failure, or they have to have diabetes, and that's where the aldosterone receptor antagonist, a drug like spironolactone or eplerenone, would be indicated. The guideline on slide 28, the guideline in terms of glycemic control has changed. It's no longer tight control. The target, the threshold, is 180 for blood sugar. You want to keep it below 180, and if you need to use insulin, you can, but it doesn't have to be an insulin drip. What was found in some of the studies was basically mortality was increased in some of these critical care trials because tight glycemic control often led to hypoglycemia. And that may be bad in the setting of infarction. So long-term management of diabetes in MI patients, very important, we know that. Keep the A1C below 7. But in the short term, 180 is the target. Magnesium generally is not used to treat MI, only if the patient is hypomagnesemic or has torsade. But in short, of those two indications, do not use magnesium as a treatment to treat myocardial infarction. Calcium channel blockers are generally contraindicated in Stemi. Now, long term, if you have an issue with ischemia and the patient can't tolerate a beta blocker, then there is the potential. You might consider using calcium channel blocker in that setting. But in the acute early phase of Stemi, don't use calcium channel blockers. Particularly short-acting dihydropyridines are contraindicated. Rapamycin, will worsen contractility. They can cause heart block. So, you need to make sure that if the patient, has any kind of heart block, they need to have a pacemaker before you start a non-dihydropyridine calcium channel blocker. So the basic premise, I think, at this point is calcium blockers should be avoided during the acute management phase of Stemi. Secondary prevention, education is very important. On slide 30, lifestyle changes and the importance of taking the drugs that reduce mortality. Patients and families should learn about the disease process, calling 911, the use of sublingual nitro. The guideline is now 1 sublingual nitro, and if you're having chest pain, call 911 right away after that sublingual nitro doesn't work. Family members should be trained in CPR. They should know how to use automatic electrical defibrillators. And so these are all things designed to make sure that patients that have another infarct survive that second infarct. Slide 31, there are a number of secondary prevention issues that need to be considered in patients post-MI. And this applies not only to STEMI, but non-STEMI. Lipid management, the target for LDL is now less than 70. Statins are the drugs of choice. We don't have a lot of evidence that altering HDL and triglycerides improves survival. The guidelines tell us what's normal and not normal, but we just don't have the data right now to say, add a fibrate or add niacin. I mean, you can do that, but there isn't a lot of hard evidence that normalizing triglycerides or HDL with drugs improves survival. We're going to have some data, soon, but the only time triglycerides really need to be paid, when they give above 500, then the risk of pancreatitis is an issue. So clearly above 500, you got to treat the triglyceride, but below that, I think it's an individualized decision. Do I add niacin or a fibrate to manage, try to manage HDL or triglyceride? Weight management, ideal body weight. Smoking cessation is very important for survival. Slide 32, antiplatelet drugs. We already talked about this. Aspirin for everybody. Dual antiplatelet therapy can be used, particularly if you have a stent. The recommended duration is 12 months unless there's a significant risk of bleeding. Now, the guidelines tell us that you can use warfarin instead of clopidogrel if the patient has an aspirin allergy. And especially if they're less than 75 years of age and can be monitored. We don't use a lot of warfarin. I mean, we don't see that many patients with aspirin allergy. I mean, there are a few. We prefer clopidogrel, but warfarin we typically reserve for warfarin-type indications, AFib, mural thrombus, DVT, those kinds of things. There are places in Europe, for instance, where warfarin is used for post-MI mortality reduction in addition to aspirin or instead of aspirin, but we just don't do that much here in the States. RAS modulators, again, we talked about the use of ACE inhibitors predominantly, aldosterone receptor antagonist if they've got poor ejection fraction, heart failure, etc. When you stop and think about post-MI, the drugs that patients should be on for survival benefit, antiplatelet drugs, beta blockers, statins, and then an ACE inhibitor. Or an ARB if they can't tolerate the ACE inhibitor. And then in special circumstances, maybe an aldosterone receptor antagonist. Slide 33, beta blockers, pretty much should be used in all patients except those at very low risk. If they have normal LV function, they were successfully reperfused, they have no arrhythmias, no contraindications, or those with contraindications, you may not have to use a beta blocker in that setting. Obviously, if it's contraindicated, you can't. But there are some very low-risk patients where beta blockers may not be all that beneficial. Blood pressure control, ideally, Less than 140/90 unless it's diabetes or renal disease, and then it's 130/80. If they've got LV dysfunction, it's actually less than 120/80 now. And again, avoid using calcium channel blockers, especially short-acting immediate release drugs to treat hypertension. Diabetes management, I mentioned earlier, A1Cs less than 7 are still recommended. And be careful with thiazolidinediones in patients that have class 3, class 4 heart failure. They're contraindicated in that setting. Slide 34, hormone therapy. This was part of the 07 guideline. Women coming in on hormone replacement therapy should have that stopped during the hospital phase of Stemi or non-ST acute coronary syndrome. Probably should not restart it. If the OBGYN physician feels they need it for a specific indication, that's a decision they're going to have to make after they're discharged from the hospital. But for most patients, do not restart, and estrogen, progesterone are definitely contraindicated during the hospital phase of acute MI. They're prothrombotic. Physical activity is recommended. Cardiac rehab is recommended if you get patients to come back for supervised exercise. Antioxidants, vitamins, minerals, none of those have been shown to reduce mortality. They don't improve outcomes. They're not recommended. Actually, a class 3 level A guideline. Warfarin is, in my mind, a bit complicated because there is old data that warfarin, again, can be used to reduce mortality post-MI. And in comparison to antiplatelet drugs, it worked as well, but it's more difficult to use. So our approach with warfarin is that if there is another reason, like AFib, DVT, large anterior MI where you have significant risk for mural thrombus, the apex is not moving, then warfarin can be added to your antiplatelet therapy with the caveat patients are at higher risk for bleeding. But it's probably better than them having a stroke from AFib. So you do need to be cautious, but there are obviously places where warfarin can be added to antiplatelet therapy in the post-STEMI patient. But we don't typically use warfarin as a primary agent to reduce mortality instead of antiplatelet therapy. So generally, when warfarin gets added, I think in most institutions it's being added as a part of a treatment for a specific indication for warfarin. For instance, someone that has valve replacement. You simply can't get by for many of those patients with antiplatelet therapy alone. So that actually concludes the presentation on ST elevation myocardial infarction. The second part of the acute coronary syndrome presentation will be on non-ST acute coronary syndrome, which is, again, the patients that develop non-ST elevated myocardial infarction and the patients that end up with unstable angina. So we'll talk about that at the next lecture. Thank you very much.